Hello, good morning everybody, and thank you for being here this morning. Today's talk is all about clinical aspects of some neurodevelopmental disorders like intellectual disability, autism and ADHD. As we had, yesterday's lecture was quite theoretical and non-interactive. So I've tried to make today's lecture a little bit more interactive, more like a workshop. So we can see some videos, we can do some assessments of our own, looking at those videos as we go along. And then what I'm going to do is, I'm going to actually give you a bit of background on the disorders first, and then I'm going to show you a video and ask you about the diagnosis. And in a couple of cases, I will show you the videos first, and then go through the symptom checklist. So today we're going to look at three things, basically: symptom recognition, comorbidity, and differential diagnoses. And I believe these things are quite relevant to the clinicians because they would like to firstly identify these disorders based on the symptomatology, and then they would be keen on diagnosing them appropriately so that they do not actually mix it up with other conditions and to understand their comorbidity. So we covered etiology in yesterday's lecture and the key characteristics of neurodevelopmental disorders. Then in the afternoon workshop, we looked at the assessment and diagnosis of these disorders. Today we're going to look at the clinical side of it, and I'm leaving the medication and the psychopharmacology towards the very end. So there's a workshop this afternoon. So if you're interested in psychopharmacology of these disorders, please come along to that workshop. So first we'll talk about intellectual disability. So we know that it starts before the age of 18. There's global impairment of intellectual function, which leads to impairment in adaptive function. And the measure of intellectual function is IQ, which stands for intelligent quotients, and we measure it using different scales like Bechdel intelligence scale for children or Bechdel intelligence scale for adults revised. So if we were to have a big sample of population at any given time in any country, in any culture, and measure their IQ and plot them on a graph, we'll get a graph like this. This is a normal shaped curve, which means that the IQ is normally distributed. If you look at this graph, 95% of people at any given time have an IQ of 70 to 130. And then there would be a group of people who would have IQ less than 70. And these are the people who would be construed as having intellectual disability. Most of the people in this population, around 2%, would have mild intellectual disability. And we talked about adaptive functioning yesterday, that it's age-appropriate behaviors necessary for people to live independently and to function safely and appropriately in daily life. And this can be actually measured using standardized assessments. So now I'm going to take you through the categories of intellectual disability and how to diagnose them clinically, rather than actually having structured assessments. So there's something, obviously it's kind of a rough guide, but you can use this guide to correctly identify the severity of intellectual disability without actually going through a lot of different tests. So if you see at this particular slide, you will see that the IQ ranges vary across the spectrum of intellectual disability. Talking about etiology, so if you look at the mild side of intellectual disability, most of the people would not have an identifiable organic cause. So they would be having low IQ due to a genetic predisposition which they've inherited from their parents. So they would, most of this group would be not actually demonstrating an underlying pathology. However, as the severity of intellectual disability increases, the organicity increases as well, and in most cases, in profound intellectual disability, you can find organic causes. Comorbidity, again, you will see only in minority of patients in mild LD, and as the intellectual disability increases, the comorbidity becomes more. Mobility, usually people with mild and moderate are fully mobile. People with severe have significant motor problems, whilst people with profound intellectual disability are severely restricted. They could be incontinent and completely dependent. Sensory impairments, they are quite rare in people with mild disability and quite common in people with profound intellectual disability. And what I mean by sensory impairments is issues with hearing, sight, touch, those kind of things really. So almost 60 to 70% of people with severe to profound intellectual disability would have hearing or visual impairments. Now that's a very busy slide, and I've taken it from DSM-4. So this actually divides different severities of intellectual disability according to the functions they can do. So if you look at, I would like to focus on two crucial areas here. Firstly, comprehension and communication. Most people with mild learning disability would have normal comprehension, normal understanding of expressed language and speech. People with moderate would have a reasonable comprehension, but they would be able to produce simple speech. And that's important because I mean there's a lot of variation in language development and language achievement in these categories. People with severe intellectual disabilities, they would have limited comprehension of simple speech, but mostly they would be either non-verbal, they would not be able to speak and they would have to use gestures and signs and symbols, or they may be able to produce simple words, like 2 or 3 words strung together in a sentence with grammatical errors, or they may be able to produce stereotypical speech. And stereotypical speech is a very important consideration once it comes to intellectual disabilities, because people may appear as if they can speak, but they have rotted some sentences, some words, and which they would repeat in certain situations. So it's really important to delineate a stereotypical speech from a normal speech. They may be able to speak some sentences or say some greetings, but that doesn't mean that they can have full-on conversation. And eventually, if you look at the profound side, they would hardly have any comprehension and very limited and no verbal communication. So they would be actually communicating to other people through gestures, signs, symbols, or even challenging behavior. The other thing to consider is the daily living skills. So people with mild intellectual disabilities would be completely independent. They would not require any support on day-to-day basis, so they can survive and live on their own. People with moderate can still live on their own, but they may need support with some complex tasks. Things like money management, paying bills, or maybe traveling in unknown environment. So with a complicated task, they may require some supervision. People with severe intellectual disabilities would need 24/7 support. So they can still do things, but they would constantly need supervision of somebody. Whereas people with profound intellectual disabilities, they are completely dependent on their carers. They cannot do anything, even for the movements or turning around or sitting, everything has to be done by their carers. Now I will show you a video and ask you to diagnose the severity of intellectual disability. So there's no sound.
He's coming. He's coming.
It just what happened. No, calcium does not slow me down. It's just what happened to me. I do have Down syndrome. I got the whole stomach on here. See, I live on my own. I clean the house, I do exercise, I walk my dog, see the outside dog. And I got 3 other brothers, still to me special.
Okay. Any comments? Any comments on what would be the severity of intellectual disability in this person's case? Mild. And why do we say that it's mild? He lives on his own, he walks his dog, he goes out on his own.
And he describes it well.
And he describes it well, his language is pretty good. Okay, fantastic.
Can we believe it? I think so.
Sorry?
Can we believe what he says?
Yeah, I think so. We have to believe our patients. Good point.
My name is Victoria. I'm a senior here at UMass studying French with a minor in education. And you may realize that I kind of like a little different than everyone else. And that's because I have an antibiotic on cerebral palsy, which means my muscles during that day sometimes little behind control.
Okay. Any comments? Can you raise the hands who say normal? Right. And the people who say it's mild? Okay. I think a lot of people are undecided. Yeah. Yeah. I mean, she doesn't have intellectual disability. Just put in this video just a red herring because of the fact that she has cerebral palsy and she has difficulty in articulation. But as you can see, she was maneuvering her own chair. She's actually in perhaps a college or university level education. So I don't think she has intellectual disability as such. I think if she didn't have cerebral palsy, she would have been able to function properly.
Beck was diagnosed just after her birth. She was in hospital for 18 days, and by the time we got home, we knew that she had cerebral palsy. Rebecca requires 24/7 support. She's described in the derogatory terms as being someone with exceptional needs, not just high needs, but exceptional needs. Cerebral palsy affects all 4 of her limbs. She has aplasia of her hip. She has scoliosis of the spine, and she's had rods put in her spine. She's got chronic lung disease. That's why she breathes so heavily. Her lungs don't function properly. What else? When we came up to meet people at Houses and Steps, they talked to Rebecca like she was a person and not just a problem that someone has to deal with. Beck's relationship with Liz is such that it's like she is an extended member of the family because she knows Rebecca so well.
Becky communicates mainly with her eyes. She looks to her right for yes and to her left for no. Can be difficult for her sometimes to control the movements, but with persistence she'll get there. Other than that, it's her facial expressions, the noises that she makes. Once you get to know Becky, you can have a long conversation with her and know exactly what she's saying. And because Becky's such a social young woman, she's just at her happiest when she's out seeing people. When Beck sees someone that she knows, her face just lights up, and I'll have a conversation with her, and she's just so excited to see someone that she knows.
Yes. So, any views on this? Serious. Right. Okay. So we saw a lady who's fully immobile. She is actually, perhaps she would not be able to transfer herself from one place to another. She is wheelchair bound. Any comments, or you wanted to say something?
Well, I was just going to say, she was clearly communicating yeses and nos and what she could do. So from my perspective, it's not my area, but it's really difficult to make a judgment when she's got such severe motor problems And we sometimes see children that people will say, oh, they're very severe learning difficulties. And they don't necessarily have that, they just have such complex motor problems that they can't express because she's got difficulty in signing and body language and all of those things. So how do you tease out that child has physical difficulty and, how do you judge that intellectually? Because a lot of the things that you were saying on this is how you decide, you can't decide for that child.
Correct, because this is a $1 million question, a million dollar comment, because people who have coordination issues with the motor movements and dysarthria and significant form of dysarthria who cannot communicate themselves, they should be able to do so using other means. And obviously, it's the next step up is that obviously they can use the signage or they can use some kind of pictures. We have something called as a picture exchange communication system, PACS, and other ways of doing it. And basically what it is that people with profound intellectual disabilities, where there's a global impairment, they will not be able to do any of these things. And secondly, the comprehension would be very limited. The most important thing to remember is that people may still be non-verbal, but they may still have comprehension, and they may be able to understand much more than what they can say. However, people may be on a pre-verbal stage, which means that there is no language development, which means that there isn't any comprehension as well. So this is why looking at comprehension is really important, to look at the comprehension side of the things as well. In cases of profound intellectual disability, people can still comprehend. They can still comprehend, but they can still comprehend to a very basic level, things to do with their basic needs, nothing beyond that. So they usually use gestures or behaviors to demonstrate what they want. And the reason they use that is because over the period of their lifetimes, they have learned to associate certain gestures with certain acts. For example, people who have been given milk before they have gone to sleep, they associate milk with going to bed. And if you present them with milk after them having this experience for a long time, they may feel that this is time to go to sleep. Similarly, if you use a sound or a gesture or an expression and associate it with an object, they would actually go by that. So for example, if every time you present water to them and you make a sound, something like bar, they would think bar means water. So it's not about the meaning of the word, but it's that they associate those words with certain actions. So in profound intellectual disability, communication still exists, but it exists to a very basic or minimal level, and it is mostly through associations with words or action or gestures. So in cases of cerebral palsy, you would actually get people on the whole spectrum of intellectual disability with no intellectual disability to the very profound end. So it could have the whole spectrum there as well. So holistically, if you look at it, her language development is right at the bottom, where she has very limited milieu of information. She's having a lot of comorbid conditions, and obviously she is fully immobile. And I'm not sure if we would be able to engage her in any intellectual assessment of intellectual function as well, because her level of intellect may not be conducive for that. So these are the pointers towards, people with profound intellectual disability would like carers as well, because they feel much more comfortable with some carers and not carers, people who have been looking after them for a long time. And they would form relationships with them. And sometimes these relationships can be quite strong, and if the carer disappears, it could actually result in difficult times for them, then going into grief reaction or becoming quite depressed afterwards. So they do actually have the ability, but that's very limited, and that's only based on the fact that somebody is providing care to them or fulfilling their needs, not a genuine relationship as people would have otherwise. So there are different pointers which you could actually put together to have an understanding of what the actual severity of learning disability is.
Do you have a very clear yes though?
Yes, that's right.
Very clear yes.
Yes.
So are there ways of using that to test her IQ?
And I think that's what they're doing actually, because that's how they're facilitating their communication. They're trying to enhance the communication by using those methodologies. And this is what the whole effort should be with such people, that we should use methodologies which can enhance communication, whether it's picture exchange method or it's another method. So that's
Text is going to be hard for her.
yeah, her hands indeed. So PAX is not going to work with her. So eyes is the one. Sometimes people have these programs on iPads as well if their hands are working. So they can actually select from the iPad, and there are certain programs for that as well. So just to give you, given all of that information, where would you like to classify her as she is? Let's say if everything which was there projected, it's how it is. So where would you put him? Which range would that be? Severe or profound? Yeah, that's right. Okay. So let's go ahead and look at.
My name is Christopher Scott, and I'm from Texas. I'm 31 years old, and I have Down syndrome. Well, I like my job. I'm a teacher assistant, and I work with kids. That's where I get some of my energy from. So I like lots of movies. Yeah, I like to go dancing, get my cool ball.
Okay, how about this one?
Good morning. Today we got something. Good morning. Good morning. Today is a good day. Good morning. Good morning. Let me to be on this beautiful day.
The type of work I do, or support I do with Rachel, is we do the day-to-day necessities, personal care. All the things you may think to do for yourself, we support Rachel in doing it for her. We always talk with her and include her with what we're doing, and she respects that. She knows that she has to do it. Rachel goes to her school, we're involved with her school services twice a week. And it is created to have a bridge between the school activities and the big world, if you like, out there in society. It helps the people involved to interact more. They get out in outings, they do lots of different exercises and crafts and communication skills that enables them to walk activities.
Okay. Any thoughts? Moderate. Okay. Yeah, it could be moderate as well, because she was saying some words, but did you realize she was repeating those things? And this is a contextual repetition of those words, a stereotypical speech we talked about earlier. This is not a proper conversation. The gentleman was actually maneuvering her chair, and she needs a very high degree of care, so she's fully dependent on others. And she does not communicate verbally, and they were using the pictures and social stories and whatnot, if you saw once she was in the school. So I would say she would be perhaps bordering on the edge of moderate to severe, right? So this gives you an example of somebody who can come across as somebody who can speak, but it's not true speech as we would see normal people, right? Okay, now we'll actually go to autistic spectrum disorder. I'm going to show you some YouTube clips, 2 or 3 of them. And what I would like you to do is to consider those the symptoms in those clips, and just kind of make a note of them and see what you can see in those clips. And then I would actually go through the description of those symptoms later on. Can everybody hear the sound? We need to increase the sound a little bit.
Just like our other series, the Happy Baby. Now we're going to see like where Thomas missing, he's not there. It's lost. I thought.
You thought? 168 children in this country have had those sort of form of autism. But if you can put aside for a moment what your pediatrician and all the other MTs have said about your son, it's these neurotypicals, the rest of us. What if we're wrong? What if we've been using the wrong tests to quantify intelligence in children with autism? Your son's not wrestling. He's different. Now your expectations for your son may change over time. They might include marriage, children, self-sufficiency. They might not. But I guarantee you, if we let the world set expectations for our children, they'll start low. And they'll stay there. Maybe your son's capable of much more than you know. And maybe, just maybe, he doesn't understand how it helps. Or we haven't yet learned how to listen. It's all right, it's fine. Can you visit with you for a while, Justine? Okay, good. Come on, folks, I'll give you the nickel tour. It's okay, come on. You'll be fine. Justine is one of our few full-time residents. She stopped talking 30 years ago. Communicates with a digital translator now.
Dr. how is Harvard funded?
We're fortunate to have very generous private donors. I'll say they're generous. Oh, why is that? But that woman, Justine, my daughter.
She's your daughter?
The reason I started the institute. Justine's computer is a BX32. Water cooled 12 core. Oh, that's right, you're a software engineer. Well, some of our donors are more generous. Why? Is that a good computer? Good. Thought she'd be back to the Pentagon already.
Sorry. Hello. Sorry for that. I think there was a crease of it almost blew everybody's ears. Yeah. So basically, you've seen a couple of symptoms there. So just keep it in mind, and we'll go to the next one.
Being held by another person is scary, but rolling or being held by surfaces produces the calming effect that ordinary children get from a hook. How old's your child? Well, I don't have children. I'm autistic. And I need the sensation of being hugged. I've developed a machine that I get into and hugs me, and I'm different afterwards. I'm more social. Well, I didn't speak until I was 4. Now I have a BA and a master's, and I'm studying for my doctorate. Most autistic people are very sensitive to sounds and colors. Overstimulation hurts. You know, people talking too much at once, you can cause us to panic. How did you get cured? Well, I'm not cured. I'll always be autistic. My mother refused to believe I wouldn't speak. And when I learned to speak, she made me go to school. And in school and at home, manners and rules were really important. They were pounded into me. I was lucky. All these things worked for me. I really worked hard to make sure that I was engaged. And I knew I was different, but not less. So I had to go. I could see the world in new ways. I could see details that other people were blind to. My mother pushed me to become self-sufficient. I worked summers in my aunt's ranch, went to boarding school and college. And those things were uncomfortable for me at first, but they helped me to open doors to new worlds.
Thank you, please. We want to hear everything.
So it seems like the internet is a bit slow. Let's try and get one. Yeah, I know. I think I will leave it at for the time being. This pretends. I'll put something else on. Okay, so I'm sorry for the technical difficulties. Yeah. So basically, I mean, if you look at these symptoms, I mean, I think you would have seen some basic symptoms of autism. So this is the DSM-5 classification. I'm going to take you through that classification very, very quickly. So there are deficits in social and communication interaction across multiple domains, and basically they have been described as issues with social and emotional reciprocity, deficits in non-verbal communicative behaviors used for social interactions, and deficits in developing, maintaining, and understanding relationship. So as you would have seen from these clips, that people may have an abnormal social approach, and they may lack the ability to have a normal two-way conversation. They may have very limited interests, and they may struggle in reading the social cues and interacting properly. And you must have also seen that people were having a very varied eye contact. They were not making an eye contact, or the eye contact was quite sustained. Equally, their bodily movements to express themselves were quite limited. They actually have difficulties in understanding gestures. And sometimes their facial expressions can be completely absent. And then they have actually difficulties in adapting and adjusting to social behavior or context, and sharing this with other people. So these are the issues to do with social and communication interactions. And then they may have restricted and repetitive patterns of behavior, interests, or hobbies. And as you've seen in one of the videos, there was a woman who was actually banging the bed, and she was, in another video, she was going in circles, and their hand flapping, their idiosyncratic movements, phrases, motor stereotypes. So these kind of things are there, which you can visibly see. And they would like to maintain the sameness or inflexible adherence to routines or utilized patterns of verbal or non-verbal behavior. So change may be quite upsetting. Sorry? Okay, sorry. So the change can be quite upsetting for them. So they would like to persist with what they know and what they're comfortable with. Any change could disrupt them. So that's another area to consider. And then they may have ritualistic and very fixed interests. So hobbies, interests, I mean, they may be good at doing something like computers or mathematics or arts, and they may be exceptionally good at that. For example, the girl in the first video was actually playing the computer and she was pretty good with it, but she's not actually good in communicating and socializing with people or understanding the social norms. And you must have seen the example of hyporeactivity to sensory input, and that was wonderfully described by one of the ladies in the video clips, that overstimulation can be overwhelming for them. They can get overwhelmed by information. Hyperacusis is very common in autism. People, if the sounds are loud, they get perturbed and they get very anxious. Equally, they have a very high threshold for pain and temperature, and they may not be able to feel the pain or temperature as normal people do. And they may have sensory-seeking behaviors. Maybe they are actually looking for soft objects to play with, or they may have fascination with toys or lights or textures or tastes. So they may have this hyporeactivity to sensory input. So these symptoms should be present in developmental period, and they should cause significant impairment in social, occupational, and other areas of function. And they should not be explained by intellectual disability, though autism and intellectual disability can co-occur, as we know. I think we have seen this yesterday, so I will not repeat that, but I will go straight to the differential diagnosis. So one of the questions asked earlier on, I think it was a few days ago, one of my colleagues asked me whether people who are deaf, could they come across as autistic? Yes, they can, obviously, because there's a sensory impairment. There could be difficulties in learning, expressing, and understanding the social norms, and that could be one of the things which need to be considered. And then, as I said earlier on as well, that there are genetic phenotypes, and autistic-like symptoms could be a presentation of that. Examples are Fragile X, tuberous sclerosis, and a host of other things. And then there are pervasive developmental disorders like Rett syndrome or childhood disintegrative disorder. So these are the phenotypes of genetic syndromes. So we need to think about whether the autism in these conditions, is it a primary autism, which is unlikely to be the case, or it's secondary, which is the presentation part of those disorders. Then there are two conditions which need to be differentiated from autism. One of them is schizoid personality disorder. We know in schizoid personality disorder, people can be aloof, and they may not be communicative, or they may not be that interactive with other people, and they may keep to themselves, and they may have odd hobbies, interests. However, as we know that ASD, you can pick up the signs and symptoms at a very early age, whereas schizoid personality disorder starts in about early adulthood. They would have early development. They would not have any communication issues, no sensory issues, and they would not have. And there are things which are very common, like social aloofness, solitary activities, restricted interests, or emotional coldness, but they would not have the other things. Whereas ASD would have a lot of the things like sensory issues, social, and may have communication deficits, and a very early onset. So that's an important differential diagnosis. The other one is OCD, because we have seen that obsessive compulsive disorder can be a comorbid condition with autistic spectrum disorder. The difference is in the age of onset. OCD usually starts from 10 years onwards. Early development is normal. The differentiating feature is that in OCD, people have recurrent, persistent, intrusive, unwanted thoughts, images, and urges, which individual constantly wants to suppress or avoid. And this is really important. These thoughts or images or urges are unwanted, and they're quite distressing and disturbing for the patient. Whereas the obsessive thoughts related to autism, they are related to hobbies and interests, and they are quite entertaining. People enjoy them. And once you take them away from them, they actually feel quite anxious. Equally, compulsions in OCD are there to suppress these intrusive thoughts or images, and people do it to overcome them and to reduce the anxiety. Whereas the ritualistic behaviors in autism are again very pleasurable. And in OCD, people do not have any sensory issues, social aloofness, solitary activities, or restrictive interests. So these are the things which would actually differentiate between the two disorders. Now, coming to attention deficit hyperactivity disorder. If we have another 10 minutes, I can show the video. Is that all right?
Yes.
Okay.
I will be collecting assignments now.
Hands, please hand it up soon.
Ken. Before I start, there will be a class test tomorrow at 10 a.m.
Okay, I think this was a very typical case of ADHD. So it's a persistent pattern of inattention or hyperactivity, attention and or hyperactivity and impulsivity that interferes with functioning or development as characterized by 1 and 2. So I'll come to that, those criteria. Where the symptoms should be present for almost 6 months, and they should be present before the age of 12. So inattention. As you can see, the guy in the video was quite inattentive because his mind was always wandering. There's a phenomenon in ADHD which is called mind wandering, where the mind doesn't stop and keeps on moving from one thing to another thing to another thing to another thing. It's constantly on the go, and it doesn't actually register what's going on. So the working memory gets affected, and people cannot take and remember information, and they get easily bored as well. They also actually, at the start of the video, he tried to find a book inside, or incitement inside his bag, which was not there because he forgot to put it there. And he's quite disorganized and chaotic in that regard because of the fact that he cannot actually organize his life, and also that he cannot concentrate on tasks on hand and complete them as he wants to. So that actually leads to a lot of different difficulties in sustaining attention for long enough to do something, not following through the instructions, appearing as he's not listening to the others, and not paying attention to the details, and then avoiding tasks and sustained mental efforts. Just to make one important point here, people with autism may be able to do the activities they like for hours and hours, and they can sustain the focus in those activities. But this is, and often the complaint is from the parents that the child can do something for long hours, but once it comes to the schoolwork or other things, they cannot concentrate. So it's very normal for people with ADHD to do certain sustained activities which they like, but anything other which requires active mental effort, that can be a problem. Hyperactivity and impulsivity, fidgeting, you saw the fidgeting over there, and he was quite actually, on one occasion he actually was quite impulsive. He lost his cool very quickly, and he shouted and ran out. People with ADHD can go on and talk and talk and talk without listening to others. They could talk over other people, and they may be very impatient in conversation. So they may not actually wait for the answer, and they could question, and they could actually blurt the answer or comments very quickly. They may interrupt the conversation or speech very often. So this is to do with hyperactivity and impulsivity. So there are 3 types of ADHD, predominantly inattentive. So this is the type which is most commonly seen in young girls as compared to boys. Then there is a predominantly hyperactive and impulsive type, and then there's a more severe type which is called the combined type. Symptoms, again, symptom severity is important because this is important for making treatment choices. In mild, there are few symptoms which actually cause minor impairments in social and occupational function, whereas in severe, there are many symptoms which actually have marked impairments in social and occupational function, and the moderate is in between the two. So this is like the psychiatric comorbidity. As you can see, that anxiety disorders and oppositional defiance disorder is quite common alongside conduct disorders and tics. So this is the kind of comorbid conditions which we find with ADHD. The important differential diagnoses are bipolar affective disorder. Again, with ADHD, you're looking at family history because it's a highly heritable disorder. It starts in early childhood, it's chronic and persistent. There's no hint of euphoria, but chronic demoralization. And basically, insomnia is unusual, and mostly delayed onset of sleep is the case. Whereas in bipolar affective disorder, you could still have a family history of severe mood disorder, starts in late adolescent and early childhood. Usually the nature is cyclical, whereas people recover in between the episodes, and that means that it's not a pervasive disorder, it's not there all the time. And then there could be issues with insomnia for several nights, and true euphoria with denial of problems. Anxiety disorders, again, they can be separated from ADHD because there's no impulsivity there. There are concerns and worries about future. They can be associated with panic attacks, and there could be physical symptoms like sweating, palpitation, dizziness, rapid and shallow breathing. Now, to say that anxiety disorder, the symptoms of anxiety disorders are not present in ADHD, and if there's a diagnosis of an anxiety disorder, that's again a comorbid diagnosis, not a part of ADHD. And one of the most common one which we come across is the borderline personality disorder. Usually because in borderline personality disorder there's a lot of impulsivity, difficulties in relationships with people, there's emotional dysregulation. So borderline personality disorder makes a very good differential diagnosis for ADHD. The important thing to remember is borderline personality disorder again is a disorder which usually starts after traumatic events in life, and it usually starts off in early teens, and then it develops from there. There is a very significant fear of abandonment. Once you speak to people, they fear that something, they would lose something, and then in order to compensate for that fear, they try to control the people they're interacting with. So they want to maintain a control on them. And there's a lot of unemotional up and down in that relationship. So the core feature of EUPD, or emotionally unstable personality disorder, or borderline personality disorder, is that people actually have a very strong fear of abandonment. And then you would see suicidal thoughts, especially self-harm in EUPD, which is not a common feature of ADHD. Again, with major depressive disorder, they are episodic, they are related to stress and trauma in life. Mood is generally depressed, and they cannot enjoy things. Appetite abnormalities and sleep difficulties are there. So I think one of the main characteristics of differentiating all these disorders from ADHD is the age of onset, family history, and the prevalent mood, because with ADHD it does not present with a mood disorder as a part of the symptomatology, though a mood disorder can be comorbid. And people with ADHD do not have anhedonia, which means inability to enjoy things. So they would be able to enjoy different activities in life. ADHD changes. So basically, as we know that approximately 8 to 9% of kids have ADHD, but once they become adults, around 60% of them carry on with the ADHD symptoms. So in adults, the hyperactivity reduces, but the hyperactivity changes from being constantly on the go or constantly on the move to become fidgety and restless. So people may not be able to relax, would not be able to simply sit still, and they're quite restless. Especially once driving, I've noticed a lot of ADHD, people who have got ADHD, they're all constantly fiddling. They are either playing with their phones, they are playing with the stereo or whatnot, and they have to do something to keep them occupied. And that leads to accidents, and that's a considerable risk. So the nature of hyperactivity changes. Attention and improves, because as people grow older, inattention becomes better. However, it is important to remember that in ADHD, symptoms can get worse from time to time, and that's especially once people are transitioning from one stage or one role to another. So during periods of stress or once demands are put on people, ADHD symptoms can get worse, especially inattention. So this is important to remember that people may have times once ADHD symptoms can get worse, especially around 17, 18, once there's a transition from junior school to higher school or university time, and then in their 20s and 30s, once people get into relationships or people actually move up the job ladder. So at that time around, the symptoms can get worse at that point in time. Okay, so the take-home messages is that we use the knowledge of identifying people and the signs and symptoms of these disorders, and we should this is really important that we should differentiate between the differential diagnoses to diagnose the condition properly, because that's really important. That's where it starts from. And separate the comorbid condition from the actual diagnosis. So with this, I thank you, and thank you for patiently listening.